what we like to do during these 1 hour and a half, is have a discussion about reorganization of health services for the COVID-19. I think this discussion is very timely, and we're now, Jamaica moved to community transmission. Other countries in the Caribbean are in a similar situation, so facing the same challenges. And I think now there's the need to, rethink and redesign the health system to provide a proper answer to potential surge of cases of COVID-19. So, the objectives of this webinar is to share country experiences and from Jamaica and Bahamas, and also present the PAHO tool on central bed management system, and have a discussion, about those two issues. We are very happy to have today with us Dr. Theodore Gandhi, the PAHO WHO representative for Jamaica, Bermuda, and the Cayman Islands. Dr. Nadine Williams, the Director of Health Services Planning and Integration. And Dr. Vivas, PAHO Advisor on Health Systems and Services for Bahamas and Turks and Caicos. Thank you very much for joining us and for your time to share with us your thoughts and your work in the reorganization of health services for the COVID-19. So to start, I would like to invite Dr. Theodore Gandhi for some opening remarks. Dr. Gandhi, thank you so much.
Good morning, everyone, and thank you for joining us this morning and to attend this webinar on bed management systems of COVID-19 response. We know that you're all very busy at this time, so we are very pleased that you've been able to join us today. The main objective of health services in response to the COVID-19 pandemic is to save lives. The capacity to respond to the pandemic will depend on multiple factors that affect the spreading of the virus in the population. Public health measures such as social distancing, quarantine, and infection control in the population can reduce the number of patients that will prevent the collapse of the health services. But also that will allow buying time for health services to reorganize and progressively expand, mitigating the impact of the pandemic until a vaccine or treatment is available. Recent experience with the SARS-CoV-2 coronavirus has shown that the case fatality rate is decisively impacted by the response capacity of the health system, including early detection of cases and access to specialized care. The expansion of hospital services requires reorganization of the healthcare network in areas or districts with the highest population and coordination through a bed management system to arrange the referral and transfer of patients. It's within this context that PAHO has organized this webinar with two main objectives: to share country experiences on the reorganization of health services and bed management for the COVID-19 pandemic response, as well as to present the PAHO WHO Central Bed Management System to improve coordination for the COVID-19 response. This session is part of a series of webinars in key areas for the COVID-19 response in Jamaica, which included the modeling of COVID-19 cases, health workforce estimation, infection prevention and control, and mental health and psychosocial support. We hope this webinar will be useful for sharing knowledge and tools and contribute to the country's COVID-19 response. Thank you, and once again for joining. Thank you once again for joining us.
Thank you very much, Dr. Gandhi. I would like now to invite Dr. Nadine Williams, Director of Health Services Planning and Integration, for a presentation of the reorganization of health service in Jamaica. Dr. Williams.
Good morning, everyone. Good morning, Dr. Gandhi. Good morning, Mr. Diaz. Good morning, Dr. Lucas. Good morning, everyone. Are you able to see my slides?
Yes, perfect. You just want to put it on slide here.
Yes, so I'm attempting to do that, yes. Are you able to see now?
Perfect, Dr. Williams, perfect.
Excellent. Thank you so much. So before I start, please allow me to say thank you so much to the Pan American Health Organization for the excellent support, direction, and guidance which has been provided to our country and the region as a whole. There have been specific ways in which you have contributed to our success thus far, and I'm really very grateful for the guidance that you continue to provide for us. And these series of webinars are certainly appreciated by our team, and I'm sure that the impact will be far-reaching. So thank you. There are ways embedded in this presentation in which you have indeed contributed, and I also want to say thank you. So thanks for this invitation to allow Jamaica to present its experience. So let me go ahead. So Jamaica has really had an experience because we started out with our first case in March and now it's August. And so we've really gone through 5 months of, well, more than 5 months of intense preparation and application to all that we have learned. Just for those who are here who may not know or about our health system, but essentially Jamaica is has a very characteristic and unique shape, we would want to admit, with a central area of hills and mountains and a peripheral flat coastline. The health system is organized in such a way we have 318 health centers, primary care health facilities, with our secondary system consisting of the lower level type C hospitals, the mid-level type B hospitals, and the higher level type A hospitals. The hospitals are governed, the operation of the hospitals are governed by 4 health authorities: the Western Regional Health Authority, the Northeast Regional Health Authority, which governs health care in the northeast part of the island, the Southeast Health Authority, and the Southern Health Authority, which I've been outlining with my pointer as we have gone along. It is important to note that the greatest part of our population, which estimates about 3 million, approximately 3 million, it resides in the southeast part of the country and therefore is governed with respect to the health care delivery by the Southeast Regional Health Authority. Our referral system allows for patients who need to have a different level of care to move certainly from our primary to our secondary care level, but with respect to the hospitals, from a type C hospital to a type B hospital and to a type A hospital. The type A hospitals, there is one that is in the western part of the country, the Cornwall Regional Hospital, and then there are 2 hospitals, the Kingston Public Hospital and the University Hospital of the West Indies, which are present in the southeast part of the country. So the referral system certainly would require, as is present in other jurisdictions, I would imagine, a certain level of organization, a written plan as to how the referral system would operate, with very discrete terms of references, an intact ambulance service, which may or may not require both public and private governance, transport support. So not only the physical structures of the vehicles, but also the capacity to support these structures, an intact communication system. So the telephones have to work, or whatever it is, whatever means of communication needs to be intact. And we need to have competent staff who are able to accompany the patients to match the level of care that they require being transported, equipped facilities, and of course services in the facilities to which patients are being referred. Their reasons for referral could be many. The service is not available at a facility. The facility may be overwhelmed physically, or the facility may be overwhelmed with respect to staff, like the staff may not be able to come out, or there's a certain number of staff members who are ill, or they're not equipped with whatever it is that they need to conduct their different tasks. There may be overcrowding at the facility and requiring movement of patients to another area, or there may be a sudden emergency situation. It is important, therefore, to recognize that referrals potentially, though it naturally moves in an upward direction from the lowest level to the highest level, could potentially have a reverse move depending on the reason, depending on the mitigating circumstances which are occurring at a particular health facility. And so I want to just identify the fact that there are several reasons for overcrowding, or which may potentiate or trigger the reason for referral. So different seasons of diseases, infectious diseases may occur, such as influenza season, the gastroenteritis season, the dengue season that we would have experienced recently, and right now our COVID season. So what are some of our responses? Very basically, I will just refer to some of the responses to that overcrowding. It may include increasing the primary care visits. So we encourage persons to utilize a primary care system a little bit more, or there may be expedited hospital care, meaning patients move through the hospital system a little bit more quickly. They're discharged if they can be discharged. There might be outsourcing of diagnostic services. There might be the use of recliners or stretchers in places where they cannot actually be moved out, or there might be the slowing of referrals into a facility which is overcrowded. I refer to these because these are some of the strategies which have been used before COVID, and which are some of the strategies which have to be used even in the context of COVID, if it is that we are going to be able to have an equitable system or a responsive system to the present situation. And so when COVID appeared, there was a dusting off of a number of plans. The plan which would have been written in the context of the preparation for the Ebola virus epidemic, the pandemic influenza plan, emergency operations plan, disaster risk management protocols, all are tools which were utilized in the development of the COVID plan. Specifically, with respect to an understanding of what would happen, we used the modeling which was utilized by the National Surveillance Unit, the epidemiology and forecasting of cases, determine exactly what it is that we were likely to face. And so I am projecting here specifically the projections for respiratory tract infections in the context of COVID-19. And so according to the modeling, which would have demonstrated and still demonstrates that the expected peak week would happen 8 weeks after the inflection point on the epi curve, it suggested that there would be the possibility of approximately 6.7 million cases of acute respiratory tract infection over the year per annum. And of those, 889,000 persons would seek medical care, with about 411,000 seeking care in public health facilities, 1,800 public hospital admissions over the year, with 360 critical care patients seeking critical care over the year. The projection would be that about approximately 55 persons would be admitted to hospital in the peak week and 11 persons to critical care during the peak week, recognizing that patients, particularly patients who require critical care, would require an extended period of care. So at the time, we would not have had the experience of understanding the expected duration of hospitalization for persons who are infected, but certainly we would have understood that there would have been a protracted period and then therefore an overlap of persons in the critical care units. And because of that, there was a projection that we would need at least 40 beds with respect to critical care beds to be available in the country, and a projection of where it, suggested that approximately 1,800 persons for the year would require hospitalization. The projection and the instruction or the recommendation was that we have approximately 20 COVID care beds per hospital if we were thinking about 19 hospitals being used. I wanted to project this as it's almost like historical now, because this would have been an example of what we experienced in early March, where we could actually identify each case. At the time, we saw that there was a beginning of a number of cases, but we were in the phase of transmission we call the sporadic cases at this time. We just had the cases we could easily identify, easily understand when they would have, which were the imported cases and how the cases were linked. We certainly would have moved far away from that since then. And so our phased action at the time was that the isolation area design was reviewed and distributed to the different hospitals and regions with a request for there to be a preparation of isolation areas. Bearing in mind the IPC measures that would have to be taken, the understanding of the way the virus was transmitted, the understanding of what was required with respect to, well, at the time we were speaking about the negative pressure needed, etc. We would have also asked them to prepare areas beyond single areas, isolation areas, and the specific areas would have been inspected and assessed. We also asked the hospitals to prepare their surge plan, which would have been certainly not knowing when the surge would have occurred or when we would have needed to utilize that plan. We would have asked the hospitals to prepare the surge plan, even as we asked them to create these COVID wards. And in a parallel way, increase capacity for caring for the critically ill. So the specific actions which I would have mentioned before would have been an attempt to create approximately 380 isolation beds in the first instance with 40 ICU or HDU areas, increasing the training of staff so the areas could be functionally workable, with a redeployment of staff, well, at least planning to redeploy staff. So this would have been included in the surge plan. With respect to an increase in the capacity for care of patients, there would have been a creation of posts with respect to doctors, nurses, community health aides, or PCAs and or PHIs. The areas which would have been areas of focus in hospitals would have been the areas of anesthesiology and intensive care, certainly our emergency care departments, and or primary care. These are areas which are prioritized. I have borrowed from the National Surveillance Unit one of the recent pictures, which really shows that times have certainly changed, because with respect to the numbers of communities, then most communities are affected when it is that they have removed the numbers of persons who have been affected by who have been affected as a result of being imported cases or related to imported cases. So when those have been removed, it is evident that most communities or many communities in the country are affected, and hence the determination that we are in fact in community transmission. Since I would have shown you that picture, and since I would have told you what our specific actions would have been, there has been a significant move. When we started initially, our total bed capacity would have been about 4,996, approximately 5,000 in terms of our capacity to deliver care in our hospitals. Of those, with respect to isolation, we had counted approximately 15 isolation areas and approximately 11 ICU and HDU beds that would have been dedicated for COVID care isolation at that time. with some regions not having clear identification of the isolation areas. Subsequently, things would have changed significantly in that we would now have achieved approximately 425 isolation beds, and our HDU ICU bed spaces, we would have achieved approximately 40, having only this week added 4 to our capacity of HDU ICU beds. And so there has been a significant move from our initial capacity of 15 isolation beds to 325 isolation beds, which we currently have. Additional strategies which would have been employed. Sorry about that. Additional strategies which would have been employed to accommodate the increase in numbers that we would have seen would have included a revision of our discharge criteria, which would have paralleled the changes in the discharge criteria from the WHO and would have been embedded in their clinical management protocol. The use of additional isolation facilities beyond our traditional facilities, and in certainly the monitoring and coordination of beds through our emergency operating center. We would have maintained core hospital services while we are delivering healthcare to our COVID patients. We would have identified additional gaps, and certainly one of the tools that we would have used would have included the hospital readiness survey, which the Pan American Health Organization, your organization, would have shared with us, and which we had disseminated to all the regions, and we would have applied that tool at least twice with a 3-month interval to identify gaps so that the individual hospitals could have increased their capacity to deliver care. Our experience has been that in the pre-COVID era, we had a certain capacity. As that capacity grew because of the instructions that we would have given to our hospitals and moved towards the ability to utilize the additional spaces, the additional persons, increase our functions with respect to being prepared for a surge, we recognize that it wasn't just an upward move, because even as hospitals prepared their spaces, they outfitted the hospitals with additional spaces, there was a lull as interim measures were put in place. So the country put in a number of containment measures, a number of treatment measures, a number of measures that would have prevented the transmission or slowed the transmission of the COVID-19 infection in community, in facilities, in the country as a whole. Consequently, the rate of climb of our cases was slowed. And there came a time when many hospitals actually had no patients in hospital. So we would have also revised not only the discharge criteria, but the admission criteria to hospital. Initially, each person who was positive, whether they were mildly positive, asymptomatic, whatever their status, they were admitted to hospital. But as time evolved, as with evolution of time and the evolution of the management and just the experience of COVID-19, we were admitting patients who required being in hospital to be in hospital, and we were improving the capacity for use of isolation at other isolation areas as well as home isolation. This then caused or resulted in a number of spaces which initially had been designated for COVID to be utilized alternately. In fact, what we then found was that as our measures might have been released a little bit, you found that more persons would have been returning to hospitals with non-COVID issues, and then would have needed admissions into our spaces originally identified as COVID spaces. So though this process map, for want of a better word, shows a movement from the pre-COVID to the interim capacity up to the surge capacity, we did find that there was a sort of reverse move as we reused the space as needed with time. And so how did we improve our capacity for critical care? There was much talk about the need for ventilators, and there was a lot of global struggle over the ventilators. We, in fact, saw that happening in front of us. ICU beds we were trying to access, ventilators we're trying to access, monitors we're trying to access, but then recognize that the ICU bed and the capacity for critical care was more than just the ICU bed, the ventilator, or the monitor. And it in fact required so much more because central to the activity, central to the function of an ICU space would not just be the bed, the ventilator or monitors, but even the correct ventilation in the area. The pumps, syringes, and suctions, the presence for the capacity for dialysis, and central to all of this are staff with the requisite capacity. So then we had to be looking about all of these additional factors to say, how do we then have an increased capacity for care for critically ill? I did mention the fact that we increased our capacity to care for persons who were positive, and we were then testing for patients to determine if they were positive, as we still are. And that is for suspected cases we were testing at the time. And then as we noted what was happening, our contacts of cases, and so the numbers grew. And we would have included them in our traditional hospitals, but also built out national isolation facilities. We utilized hotels. We would have built out national quarantine facilities. We utilized hotels for this purpose as well. So persons who were contacts or who were exposed were put in quarantine facilities as they awaited their results. And as if they tested positive, they would have been moved to either traditional hospitals as their symptomatology dictated, or they would have gone to isolation facilities if they were asymptomatic or if they were moderately symptomatic. As persons recovered from their symptomatology or recovered from the illness, if required, they would have been moving to what we called step-down or transitional facilities, where they would have spent the rest of the time, the period designated for isolation in these transitional facilities, if it is that their care, the level of care was really not mandating an in-hospital experience. Similarly, we would have been increasing with time the opportunity for persons to be isolated at home, providing the home situation allowed for safe isolation of same, whilst we tried always to maintain containment measures as well as to care and protect the families and the communities. How was all of this coordinated? I really want to emphasize the fact that, we spoke about the referral system earlier. With all that was happening with respect to the various different levels of isolation facilities, quarantine facilities, hospital facilities, and the fact that patients would have been being moved from the primary care, and I should have mentioned, most importantly at the beginning, our ports of entry, into our quarantine facilities and out into our isolation facilities, it required certain coordination. For us, the coordination was and has been and still is the Emergency Operating Center, which is operated under our Emergency Disaster Management and Special Services branch of the Ministry of Health and Wellness. And so the movement between primary care, between secondary care, between primary and secondary care or ports of entry and our many different alternate facilities had at the center of its coordination the Emergency Operating Center. So it might have proven a logistic nightmare if it were not for the fact that the EOC has been very organized with respect to their processes and the way in which they operate, because certainly they would have been instrumental in accessing or the movement of our patients through a responsive transport system, sometimes utilizing the private transport system if it were required, but for the most part, the public ambulance system. And so the further plans that we have will include increasing additional hospital beds. So increasing our bed capacity. There are plans afoot to utilize field hospital or hospitals, additional quarantine facilities, even as we prepare for the increased numbers of persons who will be affected but will not have the opportunity of staying in home or home quarantine as some persons do right now. And so still we would want to ensure that at all levels we facilitate our capacity to contain the transmission, even though we are in community transmission. So we would still need to have some capacity for additional quarantine space. In addition, we would want to have the capacity to allow for low-level monitoring for persons who may not be very ill, and the additional capacity for transitional facility, again, for persons who cannot be continuing or completing their isolation period at home. I would have mentioned before that we have reorganized the use of COVID beds. In the early part, we had a fair pace of the use of our identified COVID beds. And with time, we had a general low occupancy of these COVID beds. In our mid-experience so far, we had a return of patients with non-COVID issues returning to the facilities. Many persons had not filled their prescriptions that they would have been given, and they were pretty much staying home and not accessing the different measures that would have been put in place to allow for their continued care. And so they came back with a vengeance. And in some cases, the non-COVID beds were then overcrowded. We mentioned overcrowding earlier. This would have allowed or necessitated the reverting of beds to a non-COVID use in some instances, always recognizing that if there were a surge for COVID, there would have been the return to use of these spaces to COVID. Now, with respect to our community transmission, our experience now is that the region with the highest concentration, the region with the greatest population density, which is the southeast region, is currently experiencing 100% use of their bed space as it relates to the beds which have been identified for COVID use. And so we certainly would be at a place now where we will be tapping into the additional actions that we would have identified as necessary. So the surge plans are no longer, they have been activated and are being utilized. The further plans with respect to monitoring of bed status, I would have mentioned, but certainly with respect to the monitoring and the coordination of our bed occupancy, we are in the process right now of developing an application to do just that. We've inputted some of the information, and it utilizes our National Emergency Operating Center's GIS system. And that is what we've started doing, but certainly that is something that is being worked on. Given the dynamic nature of the bed use, this certainly is necessary. With respect to further plans for increasing our functional capacity, we will have to see how we can redeploy staff further, perhaps use additional members of staff, in addition to perhaps volunteers, increasing our critical care capacity, not just with additional ventilators, which certainly will need to be, but also alternate use of other supports, respiratory supports, such as high flow nasal cannula, which we have actually accessed and we have distributed to throughout the country. I would like to end here by saying that, by reflecting this graph, which really does reflect what is happening. I would have told you that at the beginning of our situation, we had 15 beds which had been identified as our isolation areas, and we now have 325 beds which have been put aside for COVID use. Of these, right now, we have a concentration of 99.3%. By this morning, I believe it would be 100% of those beds which have been utilized in Sierra. And therefore, this is the Southeast Regional Health Authority, in which there is in fact the greatest capacity for specialist care. The fact is that we have increased our capacity for specialist care throughout the island. And so the numbers of HDU ICU beds, which we would have identified, which we would have increased to 40, would have been throughout the country. And so I am glad and I am relieved that we are increasing that capacity throughout the country. However, do recognize also that some of the constraints, one of the major constraints, has to do with the fact that our staffing is still an issue. So I would like to end there by just showing you our coast. This is Kingston, Jamaica. And no, this is not, this is Jamaica. But I just want to end there, and I will just hand over to Mr. Diaz now. Thank you.
Thank you so much, Dr. Williams. Was great. Was great. Thank you so much. I think the information was very interesting, and it reflects clearly that in this rapidly changing context, the importance of having a health system that is resilient and that is flexible to adapt. And thank you also for remembering us that there's COVID, but there's also, as you mentioned, the influenza, the dengue, the hurricane season. So it's clearly a lot of challenge for the health system, and resilience and flexibility is clearly one of the main characteristics of the health system in these current times. Just because I think it brought a lot of things to discuss and a lot of lessons learned. Just let me just highlight. It's very impressive. The level of expansion of health services as presented. This is a very significant expansion of the health services. As you mentioned, this is challenging. This is not just beds and ventilators. It's resources and also the organization of whole system to be able to put, make sure that the patients that need are able to access these beds. So it's quite a lot of challenges here. And then also, I think another lesson very clear from the presentation is the importance of balancing the COVID-19 while maintaining essential health services. And I think it became very clear during your presentation of that importance of being able to balance that. We cannot just focus entirely on the COVID-19. We need to keep the health services for things with entities and important services. And then finally, also I think another lessons came from your presentation very clearly. The importance of primary health care. Make is very clear the primary health care in the response, and also the EOC for coordinating all the changes in the health system. So thank you so much for sharing with us the experience of Jamaica and all these lessons that you give to us. And also, just to finally mention in terms of the further plans and see how can support that, how can PAHO support that. And you mentioned the bed management system. So I think it's the right time now to call Dr. Gabriel Vivas. Bahamas team is also developing a similar bed management system. And they are facing similar challenges, and I think the trend is also very similar. So I'd like to invite now Dr. Gabriel Vivas to join us for a presentation. We put two challenges to Dr. Gabriel Vivas. And so the first one is, to present the response, the reorganization of health services to the Bahamas. And the second challenge for him is to present the tool and how the country, how Bahamas is using it and how useful it can be to ensure efficient management of the bed. Dr. Gabriel Vivas, as I told you, Dr. Gabriel Vivas is the PAHO Health Systems and Services Advisor in the Bahamas and Turks and Caicos. So welcome, Dr. Gabriel Vivas. Please, the floor is yours.
Thank you, Casemiro, and good morning to everyone. Dr. Gandhi, Dr. Williams, and other participants. So it's a great pleasure for me to share the experience of what we're working on here in the Bahamas. Of course, we have some similarities and, of course, other very unique things of what's happening here in the Bahamas. So I'm going to try to... Can you see the presentation in a presentation view?
Yes, perfect. Thank you.
Okay, so thanks again for the opportunity for me to present what's going on here in the Bahamas. And my presentation will be, as Casimiro mentioned, be like in two parts. The first will be presenting very quickly the situation of the COVID pandemic here in the Bahamas, and then I will go a little bit how the country has been dealing with the planning on the bed capacity and the service response throughout the archipelago. So just to give you the most updated numbers, this is from yesterday. We have currently over 2,800 cases with 65 deaths, and we have some deaths under investigation. And we monitor, as you see here in our dashboard that is actually shared daily, the number of cases that are actually hospitalized with any COVID-related situation. And we also report the accumulated or cumulative number of tests, COVID tests completed. And this is basically RT-PCR. We are not using any other type of rapid test for the diagnosis and monitoring of cases. So basically, we have had during the pandemic cases in over 14 of the islands of the archipelago, and pretty much the outbreak is concentrated in the capital, in New Providence and Grand Bahama, where we have most of the population of the Bahamas. That is pretty much 400,000 currently. So pretty much of what happened in Jamaica and other Caribbean countries, our first case started in early March of this year. And as you see very clear, I'm showing here the situation of New Providence. That basically is where we have most of our population here. And basically we had like two waves. The first wave that actually lasted until pretty much early May, and we had only a few cases. We had only over 100 cases and over 10 deaths. And then when the different public health measures were put in place and the closing of the borders, actually we had a very good period with basically only few cases and some days without cases, until the decision of the government in July to open the reopening of the borders in July, so 5 days later, we started to have cases. And from the analysis that we did of this importation of cases, basically, most of them were related to Bahamians that actually traveled to the US and returned back to the country. So it was a very interesting finding. Only few visitors were actually part of this second surge in the Bahamas. So you see the big difference. Basically, since the second surge or wave started, it was exponential, the increase, and pretty much in New Providence, we're still having important number of cases daily, with an average of 60, 50 cases per day. In the case of Grand Bahama, that actually was the first hotspot in the second wave for the Bahamas. Started a little bit earlier than New Providence in the second wave. We are seeing a flattening of the curve with fewer cases. Additional measures were taking place earlier in Grand Bahama with a full lockdown that actually supported a little bit more, and plus the other public health measures to flatten the curve. So now we're having only a few cases in the past days. Just to give you some differences, because this second wave has been very different from the first wave. And we're seeing here in the lower part is the cases by age group. And we see that in the first wave, basically they were mostly between 40 and 60 years. But the second wave, that is the upper part of the graphic, we accounted most of the cases with more younger people, from 20s and 40s. So that's actually provides a little differences of how we organize the services, because here we had like more adult persons, elderly persons with a lot of comorbidities, and here we're seeing more younger people with less comorbidities. And initially we had less hospitalizations in the initial part of the second wave. So just to show you, that's one of the results of the surveillance task force that actually had to put in place, because for the first wave, it was, as Jamaica was mentioning, it was very easy to monitor each of the cases because there only were a few. But with this massive second surge, actually we had to, or the Ministry of Health had to put in place a contact tracing center where they have over 100 persons actually monitoring all the cases and contacts, and be able to do their contact tracing activity. So this is just a depiction of New Providence, where basically most of the cases are located in the most populated areas in the east of the island. Just to give you one of the examples of the situation of the clusters, the outbreak here is classified as cluster of cases still. I think in Grand Bahama, probably we had a community transmission that has been stopped. And for example, I'm showing you one of the clusters that actually was one of the healthcare facilities where we had an important number of healthcare workers and patients with COVID positive, and that's the red dots, and the blue dots is the contacts that actually needed to be traced with these cases that we're showing. This was one of the biggest clusters that we actually had to monitor. Some other examples. This is in Providence also, with cases with a very large number of contacts that actually it was a challenge to be able to monitor them and contact them to do the contact tracing. So one of the other situations that the Bahamas has faced is having an important number of healthcare workers being positive, and that's throughout the healthcare services and in the main islands. So basically, so far we had over 70 cases that are being positive. And also the other situation that we had to actually put in quarantine a larger number of healthcare workers when these cases appear in the different islands, and that accounted over 600 cases that we needed to quarantine in different moments during the pandemic that actually caused a lot of difficulties actually to provide the services in the regular health care system. So we also have an important number of cases in isolation. Most of them are being like mild cases or asymptomatic that actually does not need a hospitalization to be monitored, and others are being placed, of course, at the public hospitals, private hospitals. And we also, the Bahamas also have placed some isolation facilities for people that cannot be isolated at home, as Jamaica mentioned also. But that's actually is being very low for these cases to be isolated in government isolation facilities. Just to show you a little bit of the analysis that we have done with the contacts of the cases, and basically the exposure of these contacts mainly almost 50% was occurred in the family or the home setting, and important percentage of 20% happened at the workplace. So this is a very important information that helps us actually work through the contact tracing. So in average, in the second wave, we're having between 50 and 60 patients hospitalized per day. And I'm going to talk a little bit more how we have this organized with the public hospital and actually with the private hospital, and also the expansion of some beds that actually were put in place since the first wave of the outbreak. So basically, the Bahamas have two public hospitals, one tertiary hospital that is the Princess Margaret Hospital that is based here in Nassau. And we have another hospital that is secondary tertiary, that is the Randomore Hospital in Grand Bahama. So basically, those are the two hospitals that actually we have with hospitalization services. And additionally, we have another private hospital in Nassau, New Providence, that is Doctors Hospital with also the capacity of ICU services. So the decision of the Bahamas was actually that the main hospital, that is the PMH, Princess Margaret Hospital, was not going initially to have capacity for having beds for COVID patients. So the idea was to be the main entrance of the severe and critical cases, and then refer to the other institutions that actually was identified to keep those severe and critical patients. Nevertheless, they invested in creating a modular unit outside of the hospital to have a 4 beds capacity space with negative pressure to be able to have whether suspected cases or COVID cases. And these 4 beds actually have the capacity to be step up to be ICU services. So depending on the needs, the beds will be used for inpatient beds or for ICU care if needed. The other area that actually the hospital has with also negative pressure has a ward that it was intended to have only suspected cases until they received like the results of the COVID tests with a capacity of 10 beds. With the surge of cases in the second part of the outbreak, basically this area has been used actually to keep the COVID patients needing services, whether severe or critical. The other thing is that we have the local capacity at the hospital to perform the RT-PCR test. Bajo donated an inexpert machine where actually can have the results in 45 minutes. So that was very useful to actually to be able to make the resolution of the case if it was COVID or not COVID, and actually to refer to other institution or to send them back home for isolation or for quarantine. So basically, that's what we have in the PMH. Sorry. Public health clinic in New Providence was also identified to be part of the network to have the capacity for COVID patients. So South Beach Health Clinic, that initially was a primary healthcare clinic, put in place the capacity of 10 beds. And now we're expanding the capacity with additional 16 beds. And this is only COVID patients that actually are being cared here. And they also have the possibility to have a triage component at the entrance of the health center and for sample collection. One of the good things that happened during this pandemic, actually having partnership with the private sector. So basically, since the first wave, one of the primary health facilities of doctors, hospital actually share all their capacity for the response of the COVID pandemic. So there we have a capacity of 22 beds, also for severe and critical beds, and they have the capacity also of having 3 to 4 ICU beds, depending on the necessity. And now they're also expanding additional beds in the coming weeks. We have also Doctors Hospital East, that is like the tertiary private clinic, that they have capacity of 4 to 6 beds in this facility. They also have the capacity actually to doing the RT-PCR test, so that's very useful. That also had helped the public sector for the testing of the COVID cases. In Grand Bahama, basically we have the Brown Memorial Hospital. Just remember that this hospital was partially destroyed with Hurricane Dorian last year. So pretty much the Bahamas have been working really, really hard to put back in place most of the hospital. So currently we have 10 inpatient beds and it was also identified other private facilities that actually are providing some other additional beds near the hospital. So basically we have 15 beds capacity in Grand Bahama as being the second island with most population in the Bahamas. In the second search, they also identify a hotel that initially was thought to maybe have placed suspected cases. but then it turned to actually be hosting only non-COVID patients with not much need of hospital services. So there we have 18 beds that actually at this moment, only a few beds have been utilized for this purpose. So in all the planning and the analysis of the Ministry of Health, and actually the EOC is also operational since the beginning of the pandemic, where most of the decisions are done. So they started to use the tool that actually I'm gonna explain a little bit later, so they can in a way have some information for do their planning. And the other thing is that it's very important to not only have the availability to do the planning of the beds, but also of other necessary resources of human resources, equipment and supplies. And in the case of the Bahamas, the biggest challenge, as Jamaica mentioned also, is the healthcare workers. So right now, Bahamas has a lot of difficulties trying to attract additional personnel to work in the COVID response. And currently they're trying to find different ways to attract some of these professionals from the private sector, some retirees, and second option is maybe explore bringing some professionals from other countries. So they are reviewing their bilateral agreements with Cuba, Philippines, and other countries to see if there's the possibility to bring some staff from those countries. The other very important element is actually, since we started to use this tool, is having a daily or at least a weekly monitoring of the hospital bed capacity. So basically, that was part of the tasks of the contact tracing team. So it's not only having the cases that we have in isolation in the different facilities or at home, but they also have to monitor all the hospitalized patients, and also having the information of the availability of beds in the different facilities that we have currently services for COVID patients. That has been very useful, and to be able to see if patients need to move from one facility to another, the reference of patients within the Nassau and Grand Bahama. For the other family islands, since we don't have any bed capacity, basically if we have a severe or a critical care, that patient need to be referred to basically to New Providence. So New Providence is basically capturing all these patients from all the other family islands. So the other things that the Bahamas has been doing and currently has put in place like a group, a task force, basically only analyzing the bed expansion in other hospital areas, and also trying to see other alternative medical care sites, whether it's a gym, hangar, hotels, etc. Because they have realized that actually the situation of the outbreak is gonna last for long, unfortunately. And although we're improving this second wave, we're pretty much sure that once the borders are open again, we're gonna have a third wave, and that could last for more than months. So they need to be prepared for more bed expansion. The other key element that they have identified is the triage services. at the beginning of the attention. So basically, identify which are a case or a potential case before accessing to the hospital care, to able to move them to the different point of care, whether it's primary care or the hospital services. The other key element that was identified, actually having the laboratory capacities at hospital level. At the beginning of the second wave, with the number of samples that needed to be processed at the laboratory, we had a huge backlog of samples to be tested. And some of them actually were patients who were at hospital level. They were suspected and they needed a confirmation of their COVID status. So currently, having the results in a very short time with this gene expert machine in less than an hour. So that helps the attending physicians to make quick decisions to see if the patient should stay, should be moved to another facility, or should be sent back home for isolation. The other element that is being put in place in recent times is actually to have a management in a centralized way of the hospital beds. So basically the EOC has that information daily and provides all the information to the different other facilities to see what is the capacity that we have daily and the needed movements from one facility to another, so the patients can be best managed and the beds are efficiently used in the health sector. The other key component, and actually was mentioned from the Jamaica presentation, and Casimiro also mentioned, is the importance of the primary healthcare network. So basically, most of the clinics in the family islands have identified like isolation capacities in case of having asymptomatic patients and treat them there, or once they're sent back to home isolation, to have a team to monitor these cases. So that has supported actually to avoid actually sending patients to the hospital services and sending patients here to New Providence, that actually the capacity is at max currently. So we also mentioned about the home isolation, and since a big percentage of the cases in the second wave are younger with less comorbidities, we have an important number of cases isolated at home. And in this situation, the challenge has been actually being able to monitor them periodically, and this has been a task that has been taken from the contact tracing group. So they monitor them at least 3 times during the 14 days of the isolation period, and that information is recorded in a system, so we can have information daily of this monitoring. Okay, so I'm gonna go straight to the tool, the hospital bed estimation tool that actually Bajo has developed, and it's a very simple tool. The tool has like 2 areas that actually can work in, is the estimation of the bed capacity, and also supports the estimation of human resources. But in this moment, we're only only review the bed component. And in this slide, I just show you some of the variables that we need to take into account. The first thing is that I would like to say that this estimation is based on a 30-day period analysis. So basically the calculations are done for a period of 30 days of a month. We're using as a variable average stay of stay in inpatient care in a hospital with a standard of 12 days and 15 days for critical care on ICU services. So that's two variables that actually we're using in this tool that actually can be modified depending on the situation of each country. The other variable that we're going to see a little bit later before the severity of the percentage of the severity of the cases. So we see the critical care severity, the medium severity, and we also have to work with the mild cases also. The other important information that I'm sure you keep a record of that daily is the bed occupancy rate for each of the institutions that actually have capacity in beds, and having the availability of number of beds in the inpatient and critical care. And the other thing is this tool take into consideration and the calculation of the needed beds with the number of cases of COVID cases per day. So that's another information that we need to have in order to do our different scenarios. So this is basically the information that we're going to use today. So as I mentioned, the period analysis is 30 days. We use as a standard average stay for inpatient care of 10 days and for critical care 15 days. As I mentioned before, this can be modified depending on the situation of each country, or in this case of Jamaica. That pretty much, I believe this is similar to what's happening in other Caribbean countries. The other is the severity scenarios. As I mentioned before, the tool has the opportunity to work in 3 scenarios. So we have the severe, the critical, and the mild cases. So we use one scenario using the average of what's happening in the Americas, having 12% for severe cases, 3% for critical cases, and 85% for mild cases. We use another scenario with the most studied situation that was in Wuhan, the initiation of the pandemic, with 15%, 5%, and 80% respectively. And we have a third scenario that in this case, we use what happened in the first part of the pandemic in the Bahamas. So these are the real numbers actually that we had here in the Bahamas. We used the 19.6% and 75% accordingly. So this also can be updated according to the situation of each country. So I need to change to go back to the tool. So I'm gonna share the tool. Casemiro, I don't know if you want to go to questions or I continue?
I think we just continue, and then we have the questions and answers, yeah.
Okay, perfect.
Thank you.
So here's the tool. It's a very, very easy tool to work with. We have different tabs here in the bottom. So in the first one has some instructions and explains what are the different variables and standards that are being used that I briefly explained already. Here's some introduction that actually you can click and go to the different scenarios. And we have here the 3 tabs for scenario 1, 2, and 3, where you basically have to work in some of the variables in scenario 1, and automatically the variables will update in scenario 2 and 3, and we'll see the different results. So here I'm scenario 1. So as I mentioned, the 30 days peer analysis, 10 and 15 days average stay care for inpatient and critical care. So we are in scenario 1 using the standards of what happening in the Americas of the severity of cases, 12% for severe, 3% for critical, and 85% for mild cases. So we're not going to see this upper part that actually is the analysis and calculation for human resources. And I'm going to go to this area of the tool. So here in this first cell, actually, well, that's the other thing that I need to tell you. So basically, this tool makes the estimations with the capacity of COVID beds only. So here, we're not gonna introduce the other bed capacity of the different hospitals for other services. So in the case of the Bahamas, we identified the number of beds and the facilities that actually are gonna be providing services for COVID patients. So we only do the calculation with the hospital beds for COVID response only. So that's very important, so you can use this tool very easy. The other way of using the tool, you can use it nationwide. So just having like the total bed capacity of the country and do the calculations and estimations from there. You can do it for independently for each hospital, or if you have any settlements or groups, as I was seeing in the Jamaica presentation, you can also do it by regions. So that's depending on the necessity and how this tool can be used. So in this case, I'm going to show what we recently updated for New Providence. And we included here the beds that we have for COVID response in the 2 hospitals and the other facilities in New Providence. Currently, we have 93% of occupancy rate in the different facilities in New Providence. From the 36 beds that we have for this response and the 93 occupancy rate. So currently we have only 2.5 beds available in the system. And additionally, here we put the expansion beds. So these are beds that actually have put in place other than the hospital, the hospital or other facility had. So we had 20 expansion beds in the case of New Providence. So in total, we have for response beds for inpatient, initially this is general hospital beds, we have 22.5 available beds currently in New Providence. This part takes into consideration the critical care beds. So we have the capacity of having 4 beds. As I mentioned, this can be moved a little bit because the beds can be moved from a inpatient bed and be transferred to a step-down ICU bed. So these numbers can change daily depending on the situation. And we have a 75% occupancy rate currently, and we have I think here is 1 expansion bed, actually, that we have at Doctors Hospital East that is also facilitating the ICU response for these patients. So this is the information. The ones that are in blue are the information that actually you need to include. The gray cells, you don't have to touch them because those are calculations that the tool will create. The other information is for you to decide the number of cases that actually we're gonna foresee or estimate per day. So in this case, for the past day, we've been pretty much having between 50 and 60 cases per day. So I put us as the top 60 cases per day. And in this small table, we just do a scenario construction. So we can have different calculations of the bed requirements. So it says that we're going to have results of 10 cases per day, 15, 20, up to 60 cases, the maximum cases. This number can be changed according to the situation of if you're going to do like a national analysis, region analysis, or a hospital analysis. Depending on that, you can change this scenario construction of COVID cases per day. So as we put as maximum 60 cases per day, and we have this information of the available and the occupancy rate. So this is basically the result of the tool of the need of beds that we need from this number of cases. In this first column, we have the number of cases in the scenario that actually we put in this table here that I mentioned just before. And these are the bed requirements of beds for this number of cases per day. So in the case of 10 cases per day, we need 12 beds, and we need 4.5 ICU beds. For these ICU beds, you can actually divide it if you have capacity of ICU beds or step-down beds, depending. But in general, the ICU beds will be this column. So this is one way of seeing the bed requirements regarding to the different scenario of number of cases per day. Remember that this analysis is for a 30-day analysis period. So further down, we have another table that helps us also monitor the availability and the bed requirements. So we have some color codings here, and basically this is I'm gonna put a little bit bigger this. So basically, this color coding monitoring will give us the situation of how the bed capacity is going. If it's yellow, it is between 50 and 70% of the response capacity. If it's orange, between 30 and 50, and if it's red, we have less than 30% of the capacity available. So in this case, what is happening in the Bahamas, we pretty much stretch the capacity. So here it says that for 10 beds, and here in this column, we have the cumulative number of cases that we're going to have in the 30 days. And for these 10 cases, we need 12 beds of inpatient beds, regular beds, and we only have 22 beds for this response. So pretty much we're in the orange, according to the monitoring coding, 47% response for the hospital inpatient beds. For the critical care beds, we're really bad. So we're pretty much over the capacity. So the hospitals basically they had to put in place some beds with ventilators in other areas. So we pretty much reached the capacity of the COVID response for critical patients. So remember that this scenario is based on the I'm gonna go back here on this severity in the standards that we use. So in order to see the other scenarios, we have here another tab where we see the 3 scenarios situation with the different with the differences of the severity. So we have the scenario 1. Remember the Americas. So this is the beds needs and the monitoring. This is the cases of Wuhan, scenario 2. So it's a little bit worse, the situation. using this scenario. And if we use scenario 3, that actually for what happened in the first wave for the Bahamas, we're pretty much over top of the capacity of right now. So it's a very simple tool, as I mentioned. You only have to go to this tab, scenario 1, put these different numbers on the situation, and start like doing the and playing with the different scenarios depending on the number of cases per day, the severity of the cases, and the average stay for inpatient and for critical care also. And this will provide you the information and the number of cases per day that you can give different scenarios of number of cases up to a maximum. I don't know what's the number of maximum of cases in Jamaica currently, but that's something that you just need to know. This is a very simple tool. This is only will help the Ministry of Health to plan their bed capacity and see how you will move forward to improve the bed capacity that I see in the plans that you have for the coming weeks and months. The idea is to increase the capacity of beds. Keep in mind that it's not only having more beds or more facility with beds, but you have to see the other resources. That is healthcare workers, supplies, and other equipment. We have the very not very good experiences with other countries that actually have put in place alternative sites with an important number of beds that they haven't been operational because they couldn't put the staffing for actually to manage these beds. So this is the end of my presentation. Casimiro and colleagues are open for questions.
Thank you so much, Gabriel. Thank you very much. Let me just, in continuation, also present, then this comes and might be useful also. Share content. Can you see?
Yes.
Can you see? Yes. So, and thank you very much, Gabriel, for presenting that analysis. Just to highlight, then these all come together in, on an online tool. Dr. Gabriel Vivas presented that tool that shows the estimations of the beds. Dr. Williams also mentioned the readiness assessment, which is also here. So this is we compile, or we can call it a toolkit, where all the tools have been put together, hopefully, to make it simple for the countries to use it. And so, if you see here, there is the readiness that Dr. Williams mentioned, and that can be used here, as you can see, is basically this guideline, the hospital readiness checklist for COVID-19, but in a version, online version, where you can, access and then share with the colleagues that assessment. Also, it's here. So that's the first one. Then if you go back here, there is the bed management that you see here. And this is online, so you can basically share, how many beds do you have, how many are occupied, and the level of occupation. And here you can by hospital, and then it comes to the national level or the regional level, depending of the bed. So just to let you know that, the tool that was presented, and also the tool that was mentioned by Dr. Williams, are also now online, so can be used on this online version. Thank you so much. So I'll now like to open, and I'm sorry we run a bit late. As I told you, was a challenge that we were facing in terms of time. But I would just like to open the discussion for colleagues. Any questions? Any comments?
Good morning.
Good morning. Good morning.
Good morning, Casimiro, everybody. This is Michelle Roof, Ministry of Health and Wellness, Jamaica. I just wondered, thank you for the presentations and especially on the tool. And I just wondered to what degree one can get a national picture, or do we get, is this for more local use? Each hospital uses this tool, or how do we get a national picture? Over, thank you.
If you allow me, Casimiro.
Please go ahead. Go ahead.
Yeah, so thanks for the question, Michelle. And actually, as I mentioned before, the tool can be used for both analyses. You can do a national level analysis. You just basically include all the information from your bed capacity at national level, or you can do regional or hospital analysis too. So that's the advantage of this tool. You can use them both or in different type of settings, depending on how you want to do the analysis. In the case of the Bahamas, it's a very small country, and basically we have 2 islands where we have hospitals with bed capacity. So we did actually a national analysis, and we did an independent analysis for the 2 islands. But we use the same tool. Basically, you need to modify the variables that actually the analysis that you're doing. Over.
So just to clarify then, if we enter for each hospital separately, you're saying the tool can aggregate up to regional level or national level based on the individual hospital data entered. Is that so? Over.
Correct. Yes.
Thank you. And any other comment, question? This session is both for the whole session, so for both presentations, Jamaica, Bahamas, and also as a tool. So please go ahead. No, we're good. There's no.
Casimiro, I would like to make a comment.
Please.
We don't have any questions. So basically, the best way to learn more about the tool is just start like putting like numbers with the Jamaica and starting to play with this simulation or estimation, so you will be understanding a little bit better the tool, and that's as actually this tool has been used in several Caribbean countries. Turks and Caicos is using this tool too. Grenada is also using this tool, and other countries from the region. Over.
Thank you. Thank you very much. You can also write on the chat if you prefer, or you can just open your mic. Last questions, if there's any. If not, I think we'll also continue this discussion, and we can share more information with Dr. Williams and the Ministry of Health to see how we can use these tools or see how we can also support the Ministry of Health on this very important issue as the situation, the number of cases might increase. But thank you. Any comments? Any final comments or questions? No. But thank you very much, Gabriel. I think it was interesting to see, that Bahamas is facing, there are similarities here in terms of the trends. Of course, there are specificities with 14 islands and the importance of all of them being connected. But yeah, so thank you very much for the presentation. Thank you very much for sharing the tool. Also thank you very much, Dr. Williams, for the very comprehensive and interesting presentation in the situation of Jamaica. What I suggest is also for us to share additional information about the tool and also this online this website where you can have all the tools that has been developed by PAHO to support countries in bad management. So we'll do that, and then we'll continue that discussion in another setting. But thank you so much for your attention. I think it was very useful, at least for me. I think you felt some usefulness here. We got 36 participants, so thank you so much. Thank you so much. Have a nice day.